Good afternoon and welcome. I'm Peter Traynor. I'm the Clinical Director of the Manchester Academic Health Science System, and welcome to our third in our seminar series. Can I ask people to switch off their cameras and microphones if they're joining us on Zoom, please? I can see various, it would help everybody if they could switch off the cameras. So while we're waiting for that to happen, we're going to have two 20-minute presentations, and after that, we're going to take questions at the end. So if you're watching on Zoom, you can use the chat facility to ask your questions, or you can email, if you're following on YouTube, to mahscseminars@healthinnovationmanchester.com. That's mahscseminars@healthinnovationmanchester.com. And I'll try to put your questions to the speakers at the end of the presentations. We've already received about 20 questions through the website, through the email address, and encourage them to keep coming. After today's seminar, we're going to take a break for the summer and return in the new academic year with a combination of COVID-related and non-COVID seminars that highlight some of the great clinical scientists that are in Manchester. I'd welcome your suggestions for speakers and topics. Please email them to mahscseminars@healthinnovationmanchester.com. So moving to today's seminar, understanding the mathematical modeling and epidemiology of the COVID-19 pandemic. And we have two outstanding speakers from the University of Manchester. Each will speak for 20 minutes, and then we will have conversation and questions. First, I'd like to introduce Thomas House, an Oxford graduate who's made his way north to Manchester via Sussex and Warwick universities, and is now a senior lecturer in the Department of Mathematics. He's a mathematical epidemiologist whose recent publications include such diverse topics as modeling the spread of mood and weather patterns associated with pain in chronic pain sufferers. But like many of us, his professional life has been refocused. And in the last 3 months, he's gone from publications in high-impact maths journals to being cited by the likes of The Guardian, Daily Mail, The Scotsman, Times, and even Wired. So Thomas is an individual much in demand, and I'm very grateful he's found time today to talk to us about mathematical modeling of the COVID pandemic. When he's finished, he's going to hand over to Professor Arpana Verma, an internationally respected epidemiologist. She's head of the Division of Population Health, Health Service Research and Primary Care at the University of Manchester. In addition, she's the director of the Manchester Urban Collaboration on Health, MUCH, an honorary consultant to Public Health England, and an expert opinion to the WHO. She has EU funding as the principal investigator of the European Urban Health Indicator System and is president of the European Public Health Association's Urban Health Division. She's a great speaker. She has been working very hard on the epidemiology and the impact in Manchester, and I look forward to hearing her after Thomas. So what I'm going to do is switch off my microphone and camera and hand over to Thomas.
Hello, so hopefully my slides are visible. This is my first time giving a very big Zoom seminar of this kind, so someone shout at me if they're not. As Pete suggested, it's an odd situation where things like this kind of set of rather complex equations in the top right here can suddenly become almost the most important thing in the country for just, a day, and then everything moves on. So it's a very, very odd situation and odd times, but I'm going to try and give a bit of a flavour of some of the ways that this kind of more mathematical work feeds in.
Sorry to interrupt, Thomas, but all we can see is your desktop, not your slides.
Oh, right. Okay. So I will have another go. Is that better?
Perfect. Well done. Thank you.
There we go. There had to be something wrong because we test all this before, of course, and then it doesn't work. Right. Okay. So anyway, yeah. So this is the set of equations that I said. Right. These end up being used to make quite things that I'd sort of been investigating, partly for theoretical interest, suddenly end up being the most important thing on someone quite important's agenda for at least a day. Okay. Models are ubiquitous throughout science, and really I think I'd make the statement that if you've not got a model somewhere, you're not doing science, right? I would say there's a general definition of a model as it's a system similar to the one of interest, but that is capable of manipulation in some way. So a physical model might be one that's miniaturized, right? So I like this picture of the Gainsborough Model Railway, where they've managed to reproduce something that is as close to the East Coast Main Line as you're going to get at that size, but of course it can't take you to London, right, or Leeds. But if you wanted to understand how that looks, you're going to get a far better picture of what the overall structure of that railway is than you would if you just rode the trains all day. So that you can see the model achieves something for people, but it isn't the actual system itself. I think particularly for this audience, the analogy with mice and primates as models of people is quite informative. So a lot of people will often go, well, I'm a hard-nosed biologist, you know, what's the point in modeling? It's just theoretical. And it's like, well, if you're a community that thinks a mouse is a model of a human, I think mathematical abstraction should be acceptable, right? But both have to be held to this, that equally should sign the same note of caution, right? That there's always going to be something about the model that isn't quite what you hope is going to be there in the real system, or you know is going to be there in the real system. Okay. So what a mathematical model is, as opposed to those physical models or biological model, is you take assumptions and use them to generate conclusions. Now, what mathematics lets you do is be very certain that the conclusions follow from the assumptions. So an awful lot of the uncertainty should really go from the assumptions, right, or the relationship of model to data. And we're coming up to slightly over 100 years of epidemiology, epidemiological models. So it goes back to Ross, Kermack and McKendrick. Arguably before that, Florence Nightingale and Bernoulli and others sort of prefigured some of this work. And arguably a lot of what John Snow and Samuel Weiss did and so on was pretty mathematical for the time. But the models in the format we write them down in now have existed for about 100 years. One of the questions was about the Manchester link. Now, there's been a few years where there was no substantial group, but interestingly, Bartlett, who was one of the very first mathematical epidemiologists, was at Manchester. So there is a tradition going back quite a long time here, and certainly around the Northwest. So here's our group. Like I say, normal times there's three of us, three academics, and then depending on who fancies doing a PhD with us or who's been able to get funded to work with us, we kind of sit in maths. Before this, we were thinking about supporting the hepatitis C control efforts with modelling. We developed new statistical methodology, think about new forms of data. That's the thing like this mobile health data on chronic pain. But currently, we are one of the groups providing modelling for SAGE. And there has been this quick question, did we rely too much on modelling? Well, what we do is we sit on a subcommittee of SAGE called SPI-AM, which is for modellers. So if you look at the list, it looks like there's about 50 modellers involved, but we're funneled, right? So 50 of us do the modelling, and then only one or two people from that committee go up to SAGE. And that's kind of as it should be, because modelling is unusual in that you can do it. So you can spin up lots of modelling studies and run them while there's an emergency going on, which is not necessarily true for the other there isn't so much point in having a large number of people on a standing committee in other disciplines, right? So we get commissioned bits of data analysis to do them. That's why we need the big numbers. But we're not I don't think we're particularly overrepresented at the top level of SAGE when we feed into this more technical committee. So when there's all this stuff about secret committees, I think if you knew how technical these discussions are and how much it's about, is this thing 11 or 13 or whatever, in a way, by releasing all that information, it's kind of dramatically reduced in some ways the public appetite for what we do, because it's so often technical. But I'm trying to avoid this being overly technical and show nice, hopefully nice figures and explain the kinds of things we've been asked about. So what I'm doing is just going to give 6 or 7 slides, each of which will have a few figures talking about projects we've been involved in. Most of these are big multi-author. We're all done a little bit. So the stuff's often existed in preprint for a long time, being critiqued by other peers before it was on the preprint servers. So these preprints, like medRxiv, is quite a new thing in medical science. Coming from MAHSC, the archive, the original archive, has existed since the 90s as a way of sharing work before it's peer reviewed. Now that's partly because peer review in mathematics can take about a year. It's kind of natural that people get impatient and start sharing early. But in this current emergency, this existence of preprint servers, I think, has overall been a good thing. Peer review isn't terribly good at keeping mistakes out, actually, if they're not particularly egregious mistakes. So very open science with lots of open critique, as you know, has its problems, but as I think could be a point for discussion, I think overall been for the good. So there was one question, which was what did we underestimate the speed of spread? And I think modelers did, yes. It's a controversial opinion. I think we kind of have to own that as a community and explain why. And the issue was that there were 2 problems with the Chinese data. One was that testing capacity was low. So the first country to get somewhere is going to take longer to ramp up its testing capacity. That suppressed cases. They also had, actually, probably 3 reasons. They also had to deal with that lack of testing capacity, they focused testing on people who had a link to Hubei province or Wuhan. So they probably missed local spread in other areas. And there was the fact that when you have an epicenter of an epidemic, because people are moving away, that suppresses the growth that you see in the epicenter. So we think there were 3 reasons why we kind of underestimated speed of spread working on Chinese data. And our group, towards sort of mid to late March, realized that there was enough data coming out of Europe to be pretty clear that European spread was much faster. So we were getting doubling times of between 2 and 4 days, rather than the 4 to 6 that you get out of the Chinese data. And so that is our preprint and our picture of these different European countries where we thought there was a very consistent picture, actually. And the point is that most of them did something, so you have to fit to before they start locking down, right? To know that left unchecked, coronavirus has this terrible dynamics of doubling every 3 days, but it takes you maybe 9 days for your intervention to have an effect. So you can start shutting things and you'll have 8, maybe even 10 times the number of cases before the impact of the thing you've shut is really seen, depending on whether you're thinking about impact in terms of death or hospital admissions or the other things. And this is part of the other question about where we kind of, why did coronavirus catch us off guard? A lot of it is it's so very different from flu. All the planning had been, this is another thing I think that the scientific community has to kind of own and address and just resolve, right? Because we don't want to make the same mistake again. We were probably over prepared for flu, and flu is fast. You're infectious, you're latent for a small amount of time, infectious for a small amount of time. So measures are seen very quickly. And this coronavirus has this long latent period before the impact of so you're infected and it's weeks later that events that matter for the health system happened. And there's a much more asymptomatic spread than you would get for influenza. And those two things are what have made it a really wicked pathogen to try to contain. So some other work we did was we looked at household bubbles. Without giving too much away, we looked at these very much before the government introduced them. They prioritised other things like horse racing. We were asked, lockdown has been very difficult for a lot of people. I think for those of us in professional jobs, it's maybe easier because lockdown looks a bit like the work we do on computers in the office, but at home. For other people, and even for some professionals, it's been hard, but for other people, I think it's been terribly hard. And the small households, again, have particularly felt isolated. So one thing that comes out of the modelling, so this is based on the equations on the very first slide, these quite complex equations. And we had to work quite hard with our research to get these on sort of run on fast computers. And we're still working on getting those equations sort of solvable quickly on computers. But to understand these figures, what you imagine is we're kind of quite far on the right and we move left as we unlock the lockdown. And this is kind of saying, assuming that people continue to comply with the household isolation, so staying home when you're ill, if we then let people back to work, what impact does the bubbling have? So the baseline scenario is in the top left, then you can let the ones and ones all join each other. You can let the ones randomly join larger households and so on. This turns out to be very safe. I didn't show the other one which had been thought of where you let people get into bubbles up to size 10. That's an absolute disaster. So I think this is a nice one that went unseen because you didn't see the government, who will never, maybe, you know, you didn't see them say that people up to groups up to size 10 can link up, right? Because then what you get is like the young adult household of 5 linking with the young adult household of 5. Almost certainly one of them works in healthcare or somewhere essential, so that big group of 10 is then linked to the external population and forms a big focus for future infections. So this smaller household is one of these things that's a win. You can benefit the vulnerable, the people who are struggling with lockdown without really ruining the ability to relax certain other aspects of the lockdown. Okay. So some other work we did locally with the NHS was looking at hospital length of stay. So you have to be a bit careful because the point is that you're admitted to the hospital, you can be discharged or die, go to critical care. From critical care, you can step down, then potentially be readmitted to critical care. So it's not the most complex treatment pathway, but there are multiple bits to it. And if you're thinking about planning capacity, you kind of have to capture the time and the probability of each event. So we did that using a multi-state survival analysis. This was done by some of us. Our group picked up honorary contracts at Manchester Foundation Trust to work directly with data to help with the planning. There's some, I think here the fact is again that without the model you're planning often based on so the model may be complex, but it is a systematic way of putting together that data. It's the original point that it's kind of impossible to avoid having some sort of model when someone says to you, how many beds do we have? But this is at least a model where all the assumptions are open and it's very clear how the parameters are arrived at from data. So I think it's fair to say the local NHS found this useful, and what we're trying to do is roll this out. So another point for discussion is the NHS is big, so it should be building this sort of thing, right? You know, can we have, now that software is open, we have these tools for open collaboration, hobbyists will get involved. Everywhere I've been putting these GitHub links, this is the new model for open code, collaborative development of tools. Should the NHS be something that builds these kind of analytical tools and shares them and has them developed by enthusiasts and so on? I think there's just tremendous potential for this as a way of going forwards that's been highlighted, to maybe avoid getting trapped in sort of proprietary analysis techniques that are not extendable and not clear always what they're doing. So we did some work at care homes. This is very much Ian Hall in our group. He's now co-chairing the SAGE group. But basically, if you go back to the data, you see that we were kind of in a bad way, again, by mid-March, that a lot of the growth had already happened in March. So this thing on the right, these growth rates, the growth rate is bigger than 0 if it's growing, negative than 0 if it's not growing. Growth rate of 0 is the same as the famous R value being bigger than 1, okay? So R kind of roughly speaking tells you how many people you're infecting, the growth rate tells you how quickly. And so the issue was we just had this explosion in mid-March in the care home system, and that was where the problem we had was. And then by the time that happened, the disease burden is there and was very hard to control. So that was a kind of modelling telling us where we'd gone wrong. But modelling has been supporting a lot of the measures that have been taken on the care homes and have worked to somewhat to help bring that under control going on. Then there's test and trace. Sorry, these are too many figures. But basically, you can think about modelling the effectiveness of test and trace, whether you're doing that based on symptoms, whether you automatically trace all the people in households. We have built a framework that is, it's got a high level of complexity in terms of equations. And this is another thing to get across, but it's not like a kind of SimCity type model where you have lots of individuals and you don't know what each of the numbers you put in does. We understand what every number we put in does. So there's often this thing where the more mathematical work you do, so the harder it becomes for a non-specialist to understand what your model's doing, the easier it is for a specialist to say, well, I understand exactly what every bit of my model comes from. And this is, again, maybe a point for discussion, which is how do we see that the public wants to know where this comes from for things to be open, but in one level higher, at one level higher openness is associated with impenetrability to the less mathematical scientist. So finally, extinction is a bit of a mixed bag, unfortunately. That on the right, this is different empirical disease, empirical data sets on diseases that have been subject to efforts at eradication. The unfortunate fact is we've only ever managed to get to 0 cases from quite a high prevalence once, which was smallpox. Things like polio take a long time. You get these long tails. So polio, measles, still not eradicated. Foot and mouth disease was eradicated in the UK. SARS-1 was eradicated. Ebola gets eradicated each outbreak. So it's not impossible, but our intuitions are bad about how long it takes to get to 0. So empirical evidence, but also modelling, which is this graph at the top, they do just show that 0 takes an awful lot longer than we think. And so there's an ongoing debate about, do we try to suppress how you get to 0 or mitigate? And I think that's just a difficult question. I think the honest answer, anyone who's too certain about that, to my mind, is falsely presenting certainty, right? They're claiming to be much more certain than they probably ought to be. Because the risk is if you go for 0, you use up a lot of resources, sort of societal resources, getting there, and then you might get resurgence of cases like we've seen in Beijing. And it might then be harder to deal with that. So it's the question of whether you sort of mitigate or suppress is just very difficult. And I think one that really has to be made by politicians. So modelling, it involves ultimately value judgments and decisions about things that really can't be answered purely quantitatively, but what a quantitative scientist can tell you is it maybe takes a bit longer than you think to get to 0. That's the inconvenient truth. And so finally, I hope I've kept to time just about all right. Thank you everyone for listening. Thanks to all the great people I collaborate with. Manchester Foundation Trust has been brilliant and is setting up, I think, a new unit to try and make more of this sort of thing happen. With data that Alan Turing Institute funds some of us, IBM Research. I'd worked with, supported by the Royal Society, and our group just had a kind of reasonable bit of success with getting some emergency COVID funding to keep some of this going, because a lot of it's been done by repurposing existing fundings. This was our first bit of actual support for this work that's dedicated just to COVID from EPSRC to keep developing the method. So thank you very much, everyone, and I'll stop there.
Hi, thank you, Thomas. My name's Arpana, and I'm going to do the second half of this talk and describing some of the epidemiology of coronavirus. I think it's important, as you all know, that we have the ability to do science together. And one of the key things that we have is the complexity of looking at different populations over time in a rapidly responsive global pandemic situation. We're going to have a look at some of the things that we've been doing as a unit, which also includes our systematic reviews and rapid reviews of the literature. So what I've tried to do in the talk today is link up some of the resilient systems with the burden of disease, giving you some ideas of where to go for data sources and information for the future. So as Peter said, we're very grateful to MAHSC and the university for setting up the rapid response group, where we've been able to work not only within our different faculties and health and public health systems, but also the other universities within Greater Manchester. Our division sits in the School of Health Sciences. I'm very grateful to all of the people who've done all this collaborative research with us, including the I3HS Hub, where we will be having further open access learning resources to help deal with this pandemic, as well as our MPH. I'm sure many of you know about the coronavirus from all of the work that's been done internationally to try to identify all of the different components of this new virus that came about at the latter end of 2019. We've known about this virus since the 1960s. And we know from the studies that have been done that the reservoirs not only are in humans, but also mammals, and causing a vast array of different symptoms, not just the respiratory, but also gastrointestinal and neurological disorders. What we then found was that most of the time, these diseases were of low pathogenicity. What I mean by that is they didn't cause severe disease, and that was the case until about 2002, when we had the first outbreak, and that was 29 countries, just over 8,000 cases, and over 770 deaths. That was a case fatality rate of just over 9%. We also had MERS, that presented in 2012. That was 27 countries with just over 2,000 cases and 850 deaths, but a much higher case fatality rate of 34%. This recent COVID-19 outbreak affects 188 countries with over 13 million cases and 570,000 deaths. The case fatality rate is around 4% as of yesterday. So one of the key things that we've been talking about within both the local, national and international public health system is how we build these resilient systems. And one of the key things was when we first had both SARS, avian flu, swine flu, there were different economic and contextual reasons why we might have seen a self-limiting disease. Within the current context, we have the same issues with the systems biology as we've seen previously, but what we know is we have an unexposed population without a vaccine and currently without antivirals that are helping. And so one of the key things going forwards is to look at how we actually view what happens in terms of policies for things like social distancing, physical distancing, and good hygiene. And a lot of this work has depended on some of the previous work, both done in other coronavirus outbreaks, but also with other epidemics and pandemics. One of the key things is that it's multifactorial, and we know that the spread of this current coronavirus actually follows different types of droplets, and potentially might also have an aerosol component. And I think many of you have seen this debate in the literature, where we're looking at what the actual range is of the live virus being able to cause disease, and the debate between whether this should be at 1 metre or 2 metres is really down to the fact that the models that Thomas has talked about that shows how these new novel viruses are being deposited shows both the properties of large droplets and aerosols, such as measles. And so one of the key things that we've got to look at is some of the models for being able to try to limit this spread. And one of the current hypotheses are, if it's working as an aerosol, how we look at that. And it might be forming on surfaces. And there's been many studies that have actually shown that it is still a viable organism, even a few days after it's been left on different surfaces. There's been a lot of data on how important the infection prevention and control of this is, but as of even yesterday, the current models are not 100% conclusive that we can rule out aerosol spread of this current virus. The other key issue is looking at how we either diagnose the disease and show whether people may be immune to the disease through seroconversion. And so this graph shows when it's best to test if somebody has been exposed to the disease, and also some of the issues that we have when we're looking at antibodies and when it's more likely for this disease to be causing some form of herd immunity in the population. One of the key issues that this doesn't help us with is transmissibility. And we also don't know from these data whether we can actually say if somebody has antibodies that they are indeed immune. And so the idea of an immune passport may not be possible at this moment in time. And the rationale behind this is because of the fact that there's been several studies that have shown that the virus is still viable and still being excreted by people that may not have symptoms, so either asymptomatic, as Thomas mentioned, before they get the disease or when they've been tested, but also the fact that people can carry on excreting the virus both from nasopharyngeal and also in feces for several weeks after the disease. These data are taken from multiple sources just to show the current global trends. We are no longer in the top 10 countries that Johns Hopkins reports on, and it's important to have a look at some of these key issues. So here we have the UK's epidemic curve of cases, which is pretty much dwarfed by the US cases here. And if we look at India, where the current spread is significantly higher than the UK. We've been looking at these international comparisons, and just wanted to thank Tracy and Greg and Hannah, who have been looking at work focusing on either the epidemiology and trying to work out why we're so different to other places globally, such as Germany and South Korea, in terms of the number of cases and the number of deaths, and then trying to apply what we've learned into low-income countries. One of the key things that we've done multiple pieces of research on is to look at infection prevention and control. Where there is no vaccine or cure, it's one of the key things that we need to look at. Our first study that actually looked at respiratory etiquette and hygiene when we first had the first SARS outbreak really showed that there was a significant need to look at the education, how we responded to that education, and then be able to provide adequate different messages to help with that. And one of the key things was looking at the occupational health and other contexts, as well as immunology and the pathogenicity. And I'd like to thank all the people on this slide who we have been working with to try to get these data into clinical practice. And I think one of the important things that has happened recently is the involvement of the local health protection and local authority teams. And I think the Infection Prevention and Control Services has been amazing at trying to reduce the burden of coronavirus. There are plenty of different ways that we are being tested, and this has been shown by the different pillars. And I'd like to thank our virologists and Paul Townsend and Rick Bodie, as well as Hui Go, for some of the work that we've been doing looking at how effective tests are. And the rationale behind this is to show that if you test positive, how likely is it that you actually have coronavirus? And what we can see here is when there's low cumulative incidence, we know that the tests aren't as accurate. So that means that we're getting more false negatives. So those are people who have the disease but don't test positive for the disease. And in the case of antigen testing for the PCR, that's where it's important, and vice versa for antibody testing, where we might see a lot of false positives. Some of the data that you've been seeing from the website for the government statistics have really shown the age distribution in line with what's been happening over time. And the deaths reported have equally shown a flattening of the curve, and we're past the peak of the epidemic. I'd also like to mention Ian Hall and the fantastic work he's been doing with care homes, and also the team here. We've been looking at qualitative data to try to set some of the context behind these data. And we know that we're past the peak, but what can we learn? And this is not only for any further waves of coronavirus, but also the fact that we will soon be entering winter flu season, and what can we learn in order to be able to reduce some of the key issues that we've faced this time. I'm sure many of you have seen that we've now got local measures in place. This morning, Blackburn and Darwin introduced new measures to try to halt their local data to try to reduce the burden within a particular locality. We've also been looking at some of the key things that have been shown up in this Public Health England Zero Prevalence study about those people who will actually zero convert, and what that means in terms of being able to demonstrate immunity in the future. I'd like to thank Tim and Liz, and we've been working on a strategy to try to call back people as a cohort so that we can have a look at this long term. The ONS study provides us with slightly different data. This is now where we have a sample of the population, hopefully representative, and we can see the difference that from those people that have tested positive, and also to estimate what the current percentage of the population with coronavirus is. And as you can see, we've been able to make this more accurate. It's important also to note about the age categories. It was initially thought that children might not pass on coronavirus, but this study from Germany showed that there were those children with high viral loads that were actually excreting for several weeks and could potentially have an issue in terms of looking at how transmissibility between children and adults occurs. And again, I'd like to thank Bella Bragg, Steph Mitchell, Caroline and Health Innovation Manchester for the work we've been doing with ethnicity. This is work taken that's shown for the UK, what's been happening in terms of both the IMD, so that's the Index of Multiple Deprivation, and ethnicity by different age groups. And I'll talk about this later on. Because we've been able to influence and try to look at how policy is created. I'm very keen to look at the environment and working with our colleagues to try to reduce inequalities, especially during coronavirus, but not limited to that. So I wanted to end with good news. I think what's important is that we have ways of limiting the disease. The recent REACT study has shown this morning that we are reducing the R number, and we've got lots of vaccine studies where Greater Manchester, including our own biostatisticians and clinical trial unit, actually helping with the fight against coronavirus. We've got lots of Greater Manchester studies, including mental health, with our colleagues in the Division of Psychology and Mental Health. And we've got a lot of resources that we will be putting onto our website if you'd like any further information. Thank you.
So wonderful. We just give a moment for the sort of silent applause to settle. Two excellent talks, lots of questions coming through. Thomas, you've seen some of the questions coming through, picking up some of the issues, the questions from Richard Priest. You just want to talk a little bit moment about some of the observations around bubbles, concerns about how bubbles work, the implication of schools in the context of bubbles.
Yeah, so it's worth saying a bubble, there's a distinction that we really want to make as in modelers between a bubble and maybe a cohort or a grouping at a workplace or school. So the idea of a bubble is they were posited, or the best motivation for them is childcare. So the idea would, the classical bubble that would be best motivated would be kind of single parent brings in a relative. And so the idea they're going to involve a certain amount of touch, because toddlers don't distance, they'll still touch their aunt or grandma or so on. So a bubble, you have to assume that there's the level of intensity of transmission that you get in an intimate relationship with a caregiver and child. In contrast, things like gyms and schools and so on are proposing to split the people attending them into groups and implement kind of distancing measures and other kinds of safety measures. And I would say really the honest answer, we don't know how well these work epidemiologically. What we do know is that there are well-conducted studies of pre-distancing or situations where distancing is broken down in indoor close contact environments where spread is, I've referred to it as terrifyingly fast. As in there's a Korean call center study where 1 week it's one case, then in a few days it's 10 cases, then in a few days it's 100 cases, and then they shut the call center. It is very fast. It seems, and the people who look at the droplets that Arpana was talking about seem to back this up. And so I've seen pictures from gyms of kind of them putting up shields between the equipment and so on. We just don't know. The schools, I think, again, there's the children do seem to be very, very much less at risk of severe disease, but they still seem to be perfectly capable of being infected and transmitting. And we don't, I think it's fair to say there's different hypotheses for why, which will become clearer. So saying we don't know isn't the same as saying it's a hard problem, but the relative roles of previous exposure to related but circulating coronavirus, maybe innate genetics, or your innate other things about your immune system, maybe things about different physiology of the lung, are all being proposed. And I think they'll become clearer in the next few weeks about the role of children. But the biggest risk of reopening the schools is what happens if you make a big epidemic in the children, which you say will be relatively low pathogenicity, and then they'll infect some adults. There's always going to be some leakage between different groups in society. So that's my overall comment on those. There was one other one that was a bit procedural, which I thought was interesting, about does SAGE have a single model? And very, very strongly, the modelling community says no. We really don't want that. There's you're better off asking multiple experts. And I think it's a real mistake to go too much on one model. So if you want to get something right, the climate modelers have done this, right? They make sure they average between independent groups. And similarly, the other one is various kinds of economic things are done where you ask 10 experts and take the median of those 10 experts or something. And that's always better than improving one or two of the expert things. We just know, there's reasons for that, but that would be another lecture. So those are two things that were broad themes in the questions.
So while you catch your breath, then let me just ask a question of Arpana and to comment. South Korea has a population of about 50 million. It's had 282 deaths. New Zealand has essentially gone to make the disease extinct within its own country, and has only had something like 8 deaths with a population of about 7 million. And then you look at the European experience, the British experience. What are the public health lessons, the epidemiology? How would you like to comment on that international experience, the places which have, at this stage, done well?
I think, Peter, it's something that we've been interested in, hence our international study, where we're going to be looking at trying to find the strongest predictors of low mortality, case fatality rates. And one of the key things that we know about is the strength of public health systems. So building those systems up that allows for rapid track and tracing all the way through to getting the messages out is absolutely fundamental, not just during times of pandemics, but just in normal circumstances. And I think that's one of the key things that's important for us to really discuss and debate within our devolved countries, as well as looking at our international comparators to see where we can learn from best practice, and being able to really focus on good epidemiology with hypothesis testing is one of the key ways that we're going to do it, because we're never going to be doing a randomized control trial. Our best way is good epidemiology with excellent modelling, as Thomas has shown us what to do, and being able to really focus on trying to explain some of the differences that we've been observing. But just a huge shout out to the fabulous frontline workers, both in public health and within the care homes and domiciliary care. The phenomenal response to this pandemic, we couldn't have predicted the speed of the spread in terms of it being a brand new disease. And I think one of the key things that we've learnt from our qualitative work, as well as looking at the data from the care homes themselves, is how amazing the response has been, and being able to really capture all of this good practice is what we owe everyone to do, and then get the message out.
So from where I sit, it's been very interesting when this first started to hit the UK, the conversation was all about how many ventilators we could obtain and whether we could ventilate our way out of the issue. And I suspect yourself and Thomas will have been frustrated by that conversation, because what's become apparent, and you've illustrated it beautifully, is this is pandemic management, not about how many people you can ventilate. And it's interesting, we'll come back to Thomas, to some of the comments you alluded to about politics. At some point there seems to be a decision about how much disease can you tolerate against how much isolation, physical isolation you impose. So Arpana, last comment then, on a country like New Zealand, do they not exist in a very vulnerable situation where they've essentially cut themselves off from the rest of the world, which will have an economic price to pay and make themselves very vulnerable if the disease sneaks back in? And then I'll come back to you in a moment, Thomas.
I think you're right, Peter, that there's always a balancing act, whether we're talking about ventilators versus prevention, whether we're talking about strict isolation that will have economic consequences, that will definitely have an impact on the health of a nation. These are all the balancing equations that public health professionals do all the time. That's what we're trained to do. And I think one of the key things is the differences between the way that people, both within our countries within the UK or our international partners, all looked at the data that was coming out of Wuhan, and then developed strategies, policies, and guidance based on that evidence. And that, I think, is one of the key things for having an international organisation like WHO to be able to really pull all that data together and be able to look at some of these long-term consequences. And that's why our long-term cohort is so important as we move into a different phase of this disease and try to work out then how we utilise all that data into real information that can help policy and planning for the future.
Good, thank you. Thomas, I want to come to the R number in a moment, but I was impressed in the sense that when you discussed the failings of modelling to begin with Wuhan, and you described the reasons why the models might have got it wrong, you resisted the often used shorthand of just blaming political interference, and actually there were scientific reasons and the concentration of the population, the lack of testing, the people moving out of the city. And so that was good, but we've heard an awful lot about R0 and those calculations. It's been alluded to today that the figure now is 0.57 in the UK. Do you want to just expand a little bit more about the virtues and limitations, and maybe touch upon the impact of large sporting meetings? Because you made a side swipe at the notion that racehorse was put above bubbles, but a lot of people were very conscious that 250,000 people gathered for 3 days for race meetings at in Cheltenham. And you want to talk about the modelling, the impact, the lessons learned, the benefits from not going to Old Trafford and the Etihad Stadium in large numbers?
Yes, definitely. So I think it's just, so Arpana's point with the PREVENT, that was during when PREVENT was sampling. And so that was constant with the, so I provided a bit of statistical support for the ONS study. There was this, one of the questions was, what's the community model? So React uses a model they document. In ONS, we use something called MRP, which was embarrassingly enough used by this faculty AI group to win the Brexit vote, but it's a very powerful technique that we were, and so basically R was really very low at the height of the lockdown and has now got pretty close to 1 actually. So there's not a tremendous budget of R left. Another very quick point, so this is talking around your question a little bit, is that we're used to thinking of R as a rise. R is like as an average of lots of little events. So people may have seen in the news, Germany suddenly said, oh, it's RR3, and it's because there's a cluster. And infectious diseases always cluster by their nature because one leads to another. But this one is particularly clustered, as SARS-1 was. It's dominated by random events. The epidemiology seems to be dominated by random events that cause disproportionately large numbers of transmission. And that, I think, in a way, the most instructive international comparison, it's very hard to avoid getting political. And so I will a bit, but I'll talk about Singapore, where maybe that doesn't touch as many live rails. So Singapore had the best and the worst. They had an absolutely world-leading system of test and trace and isolation that enabled them to keep lots of society running for Singaporean citizens. And Singapore has this large population of what they call guest workers, who are 14 to a dormitory, are not well integrated in society, are not in an economic position where they can not work. And they really failed to control their epidemic spectacularly in that disadvantaged population, where they would be 14 to a dormitory, 13 of them would be told you're not key workers, one of them would go out, mix with people from dozens of other different dormitories, and go back to their 14 group of bored people hanging out in a small area. And this was just an absolute public health disaster. And I think we can see that here, can't we? But through the lens of our own social inequities. So it's very hard not to see, some of these kind of issues here, but maybe less starkly than Singapore. And I think that also tells us what we should have done, right? That exactly that world lead. There's no reason we can't, as a rich country, roll out world-leading test and trace and isolate to everyone. And maybe think, I think it is true. A lot of the questions were, should we have gone earlier? And I think the fact we got ours so low during the height of the lockdown tells us we could have gone earlier and milder. very much so. So we could have had something where it wasn't just a pure trade-off. We could have got control for less cost. I do think that comes out now. That has to be a lesson we learn.
Good. And the things like large gatherings, so the large football stadia, how much do those individual events play with a disease like this in the
so that's where it comes for that exploding thing, that it's kind of like you roll the dice each time you do it, or you spin the roulette wheel, that a lot of, so if prevalence is quite low, the majority will be safe, but if you allow all of them, one of them is going to be a disaster. And really that's how I'd answer the gym question. It's a kind of it's a kind of commons or societal coordination problem. So if we it is safe, but I predict that if they all open, one of them somewhere is going to really mess it up, and there'll be a massive cluster associated with that gym. So it's hard, because going to the gym is very important for people's health, right, and well-being. So in a sense, there's no easy answer. I hope you all can see that the honest answer is yes. From your point of view, it's safe, but from society's point of view, we have to make some tough decisions about which are the priorities to release and not to release. Personally, I'm much more sympathetic to the gyms and the football than some other activities, but again, that's a political call, isn't it?
Good. So we're going to stop in 1 minute. Arpana, is there anything else you want to answer among the questions? You know, you can see Richard Priest's last question was about the risks of second waves, and if second waves are worse than first waves. Mm-hmm. So maybe that should be our last, and we'd like to leave, if we could, with a positive note about, but let's tell us the truth.
Absolute truth. I think we don't know. We know that there are likely to be more localized outbreaks now. And I think that's what we're observing, and hence why the local response is so important. I think when we look at the data, we've got to have a look at what is absolute risk and then what is relative risk, and be able to communicate that to our populations effectively and accurately. And I think that's what's going to prevent the second wave being the disaster it was with Spanish flu. And I think we've also got a lot of real intelligence now on what we have to do in terms of stopping the spread. And I think we mustn't underestimate the co-production of these different messages with our communities, whether that's our children, the teachers who teach them, the schools, and then the elderly, and our BAME populations as well. If we're going to tackle coronavirus, we have to tackle inequalities. And that means being able to really focus on those people that are at highest risk and be able to develop interventions that are going to help them the most. And I think for coronavirus, we know what to do. We just have to get on and do it now.
So I think we'll finish there. That's a note to finish on, and probably the description of a seminar we need to have after the summer, because I think that is a terribly important population from which we've got many lessons to learn and much we could do better. So look, again, to the pair of you, excellent talks, tremendous interest from our audience, very grateful. So we're going to finish there and come back again in September with our next